Thank you, Enrico. The title that Frank gave to this presentation conveys a feeling of optimism that the presentation itself showed to be undeserved. In the late 90s, the Society for Vascular Surgery, through two of its presidents, Dick Green and Enrico Asher, participated in 3 national meetings to explore the advisability of establishing vascular institutes. There were other specialties that participated in an irregular basis, and that would be cardiology, vascular medicine, and interventional radiology. At some point, Enrico Asher asked the Joint Commission and also the Intersocietal Accreditation Commission to get involved with the certification of vascular institutes, but this petition was denied. And then the leadership of the Society for Vascular Surgery decided that the Vascular Institutes project should be abandoned, and in fact it was. And meanwhile, the cardiologists promoted successfully the creation of heart and vascular institutes across the country. So even though we were one of the earliest proponents for cardiovascular institutes, we ended up having disappointingly a small role in them. Now, how small? I looked at the web pages of 50 prominent cardiovascular institutes. Only in 2 of them, there was a vascular surgeon listed as a co-director. And in those web pages, our specialty may be found relegated under the heading of vascular diseases, sharing equal billing with wound care or vein centers. In a few instances, is not even mentioned. We have seen how in some centers, the thoracoabdominal practice has shifted entirely to the cardiac surgeons, and in others, cardiologists and interventional radiologists have assumed the primary care of all peripheral arterial disease. Now, why has our relevance in the field of vascular disease become so diminished? The frequent answer is that cardiologists are more numerous than us, they see more vascular patients as they enter the health system, and their practices are more profitable for the hospital that funds the cardiovascular center. But if these facts are true today, it wasn't so when the movement towards cardiovascular centers was started. Could this have been different? When the vascular specialists of a medical center sat around the table to decide on the leadership of a cardiovascular institute, our reduced status as a subspecialty of general surgery did not help us. Consider that cardiology, even though it's listed as a division of internal medicine, functions as a department and has the full backing of the chair of medicine and the board of internal medicine. Cardiac surgery is backed by its own independent board, and like cardiology, generally has all the trappings of a department in an institution. We, on the other hand, do not. In the planning stages of a cardiovascular institute, the head of vascular surgery could only speak with the full support, or lack thereof, of the chair of the Department of Surgery. Do you think that the chair of surgery would have pushed the interest of vascular surgeons with the same intensity as cardiologists and interventional radiologists would defend their own? It may reasonably be countered that bringing up this negative effect of the dependency of our specialty is just a contrivance to add a new issue to the explanation of our lost leadership. But from what I have seen, and I have been at the conception of 2 cardiovascular institutes, our subordination to the interests of the Department of Surgery has been and is a shortcoming. Now, 10 years ago, our linkage to general surgery had some justification. There was a distant relationship between our surgical skills and those of general surgeons, and more importantly, there were then many general surgeons who included in their practice a limited number of vascular operations. But our work today is much different than what it was 10 years ago. 70% of this is endovascular. And in order to do it well, we require new skills and new alliances with other specialists outside general surgery. The endovascular transformation of most vascular surgery renders meaningless our association with the American Board of Surgery. The trend towards cardiovascular institute practices is becoming the norm, and whatever new training or practice agreements we need to develop in our future, it will happen with interventional radiology, with cardiology, with cardiac surgery, because we share with them the vascular pathology and the tools that manage it. It is natural to ask, would we be able to counter this progressive loss of relevance if we were to have a successful run at full independence in, say, 3 or 4 years? I don't know. But given that we cannot see any benefit to our practice today that can be attributed to being a, quote, pillar of general surgery, ending this subservience can at least open the door to new opportunities. And in that case, one may wish that the Society for Vascular Surgery would take us to a full recognition of our singular identity as a separate specialty. Thank you.